Trauma-Informed Care and HIV, an integrated, evidence-based model of care. This program was created and is being presented by Debbie Sestero-Seifer, MSRN. Debbie is an educator and training specialist with the North Florida AIDS Education and Training Center at the University of Florida's Department of Medicine. Debbie does not have any financial relationships with commercial entities to disclose, nor will Debbie be discussing any off-label use or investigational products during the course of this program. At the end of this learning program, participants will be able to discuss the effects of trauma on psychosocial and physical functioning, discuss the prevalence of trauma in the lives of people living with HIV, recall 2 or 3 signs and symptoms of trauma-related stress, describe 4 important principles of trauma-informed care, and finally, propose 2 interventions that modify HIV care and treatment in the clinical setting that help to create a culture of trauma-informed care. Trauma is a term used to describe a distressing event or events that may have long-lasting, harmful effects on a person's health and well-being. There are 2 important points I want to make about trauma. 1, people living with HIV are more likely to have experienced trauma during their lifetime than individuals who are not HIV positive. Second, persons who identify as LGBTQ are more likely than individuals who identify as heterosexual to have experienced traumatizing events, which include but are not limited to interpersonal violence, IPV, childhood maltreatment, trauma to a close friend or family member, and the unexpected death of a family member. Let's look for a moment at traumatizing events. What is a traumatic event? Well, there's definitely a continuum. Out of 100% population, 70% suffer from PTSD after a traumatic event. So we need to know what these traumatic events are. This image is from the ACE study. This is one of the largest studies of its kind ever conducted, and looking at adverse childhood experiences study, hence the acronym ACE. The things that the study found in a great sampling, that physical abuse by a parent, emotional abuse by a parent, sexual abuse by anyone, alcohol and or drug use, sexual assault, accidents, natural disasters, and physical assaults or witnessing death or injury is and all are considered traumatizing events. There have been some researchers who have categorized traumatic events, and this image clearly categorizes trauma into 3 types of trauma. The big T, which means big trauma, are usually major events normally seen as traumatic and include emotions, beliefs, and physical sensations that occur in both the body and the mind. The small t, or small, tiny trauma, are overwhelming but often are not seen as traumatic. These include emotions, beliefs, and physical sensations that occur in the body and the mind and may actually cause coping abilities to collapse. And finally, we have the term C traumas or chronic traumas. And these types of traumas occur repeatedly over and over again. And because of this chronicity, they often have a huge impact on the physical and emotional and social experiences of individuals. Exposure to a traumatic event or a series of traumatic events is usually accompanied by distress, and an individual's experience of trauma impacts every area of their functioning. Some research suggests that the physical effects of trauma have been related to significant health problems, such as diminished functioning of the immune system and increased susceptibility to infections. The psychological effects of trauma may manifest in increased risk taking behaviors, such as substance use, poor eating habits, or unsafe sexual activity. In addition, individuals with post traumatic stress disorder may suffer from depression, social isolation, impairments in trust and attachment, and feelings of anger. I'd like to bring to your attention the complexities of co occurring traumas. We know that individuals with a traumatic history rarely experience only a single traumatic event, but rather are likely to have experienced several episodes of traumatic exposure. Two studies I'd like to bring to your attention. One done in 2009 by Finkelhor and his colleagues showed that nearly 40% of the participants in this study had a sample of 4,549 individuals, that 40% had experienced two or more types of traumatic events in only the period of a year. And then another study done by the National Child Traumatic Stress Network found that of their sample, a sample of 11,138 individuals, over 40% had experienced four or more types of trauma. What is the prevalence of trauma in the United States? Well, we know that 60% of adults experience abuse or some types of trauma during their childhood. Men are at greater risk than women for being exposed to traumatizing events. Lesbian, gay, bisexual, and transgender persons are likely to experience various forms of trauma. And finally, people who are homeless report high levels of trauma preceding their homeless status and additional traumas occurring after they are homeless. Let's drill this down a little further and look at the prevalence of trauma among persons living with HIV. Recent studies continue to support high rates of trauma among persons living with HIV or PLWH, and often have higher rates than those reported in people who are HIV negative. A study in 2015 found reported rates of violent trauma among individuals living with HIV, and they found these rates to be between 10 and 90%, which is a very large range and has to do with the different sizes of the sampling. In a cohort of men self identifying as MSM in the Deep South and living with HIV, the respondents who were MSM were more likely than twice as likely to have experienced sexual and or physical abuse than the male respondents who identified as heterosexual. And for women living with HIV in the United States, one study found that 61% had been sexually abused, which is 5 times greater than the national rate. There are high rates of interpersonal violence being reported in studies, large and small, for individuals who are HIV positive, especially and particularly for those individuals identifying as heterosexual and are female, and men who have sex with men. Take a minute and look at this image. It says a lot, and I think the key point here is that exposure to traumatizing events can lead to increased risk-taking behavior, including substance use, unsafe sexual practices, and difficulty forming therapeutic relationships with medical personnel. People living with HIV may be affected by past traumas to the extent that it manifests in mental and behavioral health disorders, difficulties in managing chronic disease, difficulties in having healthy relationships, barriers to disclosing HIV status, and ultimately leading to non adherence to antiretroviral treatment and HIV care in general. Post traumatic stress disorder, or PTSD, occurs approximately twice as often in women than in men. It has a lifetime prevalence rate of about 1.3% to 7.8% in the general population, but prevalence rates are higher, as we discussed earlier, in people living with HIV. The likelihood of a person developing PTSD varies according to the vulnerability of the affected person and the severity of the stressor or stressors. And the most or more severe the trauma, the more likely a person will develop PTSD. Among people with severe mental illness such as schizophrenia and bipolar disorder, comorbid PTSD is an important predictor of HIV infection. Let's take a look at trauma and the distress that often comes after a traumatizing event. On the left side of the slide, you'll see the initial response to a traumatic event. An individual may be revved up and overwhelmed. They may be irritable, hypervigilant. They may be impatient, have an exaggerated startle response, increased emotionality, and may be withdrawn and having sleep and appetite disturbances. On the right side of your screen, you see the signs and indicators of a stress disorder. Things like hyperarousal, avoidance, intrusive thoughts or memories that interfere with activities of daily living, emotional numbing, withdrawal from friends and family, depression, and maybe even substance use. Stress disorders create psychological, emotional, cognitive, and behavioral changes, and they may occur within a month of the incident. This would include our big traumas, our little traumas, or our chronic traumas. And these disturbances have to last for at least 2 days, but not more than 4 weeks. This may be something we would expect from someone who's experiencing these traumas. And these experiences or emotions interfere with an individual's ability to function at their job, at school, and it interferes with their ability to obtain and use support. By re experiencing the trauma through intrusive distressing, there is that repeated recollection of the event and oftentimes avoidance of places, people, and activities that are reminders of the trauma or traumas. Well, like most things in health and wellness, trauma to recovery begins with identification. And we're going to talk more as we move forward in this program on becoming trauma informed. And I can't think of a better lead in than thinking that trauma may be the elephant in the room. How do we get from identification of trauma and its ill effects to recovery? Well, we know that trauma is one of the most avoided, ignored, belittled, denied, misunderstood, and untreated cause of suffering for many individuals in our society. Efforts to address trauma and PTSD should be a priority in HIV prevention and care, and screening and referrals for recent and past traumatic events and PTSD should be a core component of HIV treatment. I want to be really clear that I truly believe that the focus of recovery is not on what is wrong with the patient, but rather what has happened for them, what has happened to them, what have they experienced. What is trauma informed care? Trauma informed care is an approach to the delivery of behavioral health services that includes an understanding of trauma and the impact it can have on individual behavior. There are three key elements when we talk about being trauma informed as a healthcare provider. One, we need to realize the prevalence of trauma. Two, We need to recognize how trauma affects all individuals at all ages, including organizations and individuals in the healthcare workforce. And finally, to put the knowledge of trauma into practice. Secondary trauma, also known as vicarious trauma, is often not addressed in healthcare clinics and organizations. Specific trauma informed interventions are recommended in the literature. However, more research needs to be done in order to create evidence based interventions. Screening for trauma. As we said initially, the identification of the experience of trauma is the first step. The primary care PTSD screen, or PCPTSD, is on the right side of your screen. You can see the scale, the instructions, and the 4 questions that have been placed on this scale. There's good reliability and validity. The 4 questions, the way it's scored, a yes to 3 of the 4 questions constitutes a positive screen, and a referral is suggested for further assessment. A way to introduce screening to a patient when you're screening for trauma might be, I'm concerned about your emotional well-being as well as your physical health, and I'd like to ask you a few questions. When we talk about an organization and a group of healthcare professionals who provide trauma-informed care, or TIC, we're talking about a strengths-based service delivery approach that's grounded in understanding and responsiveness to the impact of trauma in our patients' lives. We're looking at emphasizing physical, psychological, and emotional safety for both providers and survivors. And we want to create opportunities for survivors to rebuild a sense of control and empowerment. Such a system of TIC, or trauma informed care, demonstrates vigilance in anticipating and avoiding practices that could re traumatize an individual who has already had a history of trauma. And finally, trauma informed care means upholding the importance of consumer participation in the development, delivery, and evaluation of services. There are 6 core practice guidelines to help professionals provide sensitive care to individuals who may have experienced one or more traumas. These guidelines include: 1, safety, highest priority; 2, trustworthiness and transparency; 3, peer support; 4, collaboration and mutuality; 5, empowerment, voice, and choice; and 6, cultural, historical, and gender issues. And in relationship to 6, I'd like to say that we're working on developing specific trauma-informed interventions that address uh, healthcare disparities for certain populations. If we look at men who have sex with men specifically, creating a sensitive practice intervention for this population might include creating a trauma sensitive practice environment, identification of trauma and its mediators, and education to patients about the relationship between trauma and its negative impact on health and wellness. Let's look at gender and trauma and some examples of what survivors of childhood sexual abuse may bring to their healthcare encounters. For women who have been socialized to be submissive, and that is combined with a child's normal tendency to engage in self blame for negative experiences involving adults, this may cause a female survivor of sexual trauma to believe that they are bad and responsible for the abuse. They may have a mistrust of authority figures and thus a mistrust of their medical providers. Men who are socialized to be strong and independent, this may complicate interactions for male survivors in that they will have challenges in sharing their lived experiences of sexual trauma because this would be an admission of vulnerability in a society or culture where there are few models of the expression of masculine vulnerability. And childhood sexual traumas can bring about questions of sexuality and sexual orientation for many of our young people as they grow up. When clients have difficulty expressing their needs to healthcare providers because of their traumatizing experiences, they may avoid speaking up or questioning their treatment plans or their medical care. Oftentimes, there are triggers or flashbacks that occur that may preoccupy a patient while they're in the clinic setting, potentially even in the waiting room or sitting in the emergency department. And often we see disassociation, a disruption in the usually integrated function of consciousness, memory, identity, and perception of the environment. So a client may start daydreaming or have lapses in attention, maybe even while speaking with you, having difficulty integrating thoughts, feelings, and actions. These are just examples, but they give us some keys into what the client brings to the healthcare environment. Trauma may negatively influence an individual's access and engagement in primary and or HIV care. We see this behaviorally through the avoidance of medical, dental, and behavioral health appointments, for example. Non adherence to treatment, such as taking medications, or not coming to follow up appointments. We also see individuals postpone healthcare services until their condition deteriorates and symptoms progress. I've seen this a lot in the Caribbean region where I'm from, where an individual waits months and months before following up, let's say, with an oncologist. And then at that point, at that late date, their options become limited and the chance for treatment and improved health are greatly diminished. We also see misuse of medical treatment services by individuals who have experienced trauma. So the recidivism in the use of the emergency department and pain medication usage repeatedly may be an indicator of someone's experience of trauma and traumatizing events. There are three important key messages that patients need to hear from their healthcare team members. This is for all patients, being that we don't exactly know which individuals may have experienced traumatizing events until they tell us. One, we need to let every patient know that everything they share with us is confidential within the boundaries of the team of healthcare professionals they have chosen to provide their care. In addition, we want to inform our patients that they can share unsettling life events that they have experienced with us, and that we respect them and their decision if they choose not to. And finally, We want to let our patients know that if they have experienced unsettling life events, that we will provide them with information and guidance on steps they can take to address these concerns. Very difficult life events in childhood or adulthood can negatively affect a person's emotion, social, and physical health. We need to let our patients know that difficult life events include sexual or physical abuse, emotional abuse, loss of loved ones, growing up in poverty, loss of property, home, or livelihood, serious accidents, being the victim or witnessing a crime, having a serious illness and intense medical procedures that have occurred in their life. And some of these events may make a person very sensitive to and uncomfortable with going to a healthcare provider or going to the dentist and having different tests, having blood drawn, for example. Letting our patients know that their comfort and care is our top priority, and we will explain what we do and why we do it. For patients who do relate and share traumatic experiences to their providers, we want to provide a brief, empathetic, validating message to the patient. For example, I'm sorry this happened to you. No one should have to face such upsetting and scary situations. Another example might be when the provider says, we know there is a direct relationship between stressful and traumatic life experiences and a person's physical and emotional health. What opportunities, if any, have you had to discuss these things with a healthcare provider or counselor? I hope this short slide set on trauma and working with individuals who have experienced trauma has been a good learning experience, and that you'll take away some important points and start integrating some of these ideas into your practice so you too can be practicing trauma informed care. In summary, providing trauma informed care is about creating safe and sensitive environments for our patients, and I would add non judgmental as well. We want to communicate sensitively to individuals who have experienced traumatizing events and provide brief, empathic responses to individuals who do report experiencing trauma or traumas. And most importantly, we want to be sure that we are consistently providing services in a trauma informed care. All of us, the entire interprofessional team. Thank you so much for joining me on this journey of looking at how to provide trauma informed care and what are the needs of our patients who have experienced trauma and who may still be experiencing traumatic events in their life. These additional resources on trauma informed care may be helpful to you and your interprofessional healthcare teams. Thank you so much for joining me on this journey, a short one, on the needs of individuals who have experienced traumatizing events and may still be experiencing traumatizing events. I hope you will use the information in this slide set as well as the additional resources listed on this page to inform you on how to better provide trauma informed care to your patients. And I hope you'll talk about this in your interprofessional teams and look at ways that you as a team can be consistent in providing this care. My name is Debbie Sestero Seifer, and I thank you for participating in this learning module. My contact information at the University of Florida is presented on this slide, and I hope you will contact me if you need further information or have questions for me about trauma and trauma-informed care. I wish you and your interprofessional teams much success as you address the holistic health needs of your patient, Morgan Rivera, as she learns to identify her strengths in managing her life and the hope she has as an individual living with HIV.